Welcome to this clinical walkthrough on a venous leg ulcer case for UKMLA, brought to you by Medidate, your 24/7 practice partner.
So here we have a classic follow-up scenario. But what's the real test here? It's not just about your clinical knowledge of venous ulcers. The real challenge, and where a lot of people can stumble, is figuring out what to do when your patient says no. This whole case is about managing expectations and building trust just as much as it is about managing the ulcer itself. Let's dive in. Okay, let's set the scene. Picture this. You're an FY2 in a busy GP surgery. An 80-year-old gentleman comes in for a follow-up on his venous ulcer. The critical piece of information here, the treatment you started him on isn't working, and frankly, he's frustrated. How you handle these first few moments is going to set the tone for the entire consultation. First things first, you've got to start strong. Always begin with a clear, warm, professional introduction and confirm who you're speaking to. This isn't just a tick box exercise. It's step one in building rapport, and it's a critical safety check. After that, set the agenda. A great tip is to mention you've already reviewed their notes. It shows you're prepared and you respect their time, which can really help bring down the tension with a frustrated patient. Right, now it's time to gather that history. The key word here is focused. You're not starting from a blank slate. This is a follow-up. The examiners want to see that you can be methodical and efficient, but also show genuine empathy for what the patient is going through. So the patient tells you straight up, the compression stockings are just intolerable and this thing is not healing. That's your cue to dig in a little deeper. Now, it's really reassuring that he's not mentioning any red flags like pus or feeling unwell, but you still need to proactively screen for those venous risk factors. You know, things like a job that involved a lot of standing or varicose veins running in the family. This just helps you cement that diagnosis in your mind. And this leads us to an absolutely crucial tool for any communication station, ICE. Ideas, concerns, and expectations. This is your secret weapon to find out what the patient is really thinking. And look what we've uncovered. His main concern is that it's not getting better, and his expectation is that he wants to see a doctor, not a nurse. Nailing these points is so important because these are the exact hurdles you'll need to address in your management plan.
Okay, so before we even think about a new plan, we have to deal with the information we already have. In this case, the nurse has already done a really important test, the ankle brachial pressure index, or ABPI. Your job now is to take that clinical data and explain it in a way the patient can actually understand. So what on earth is an ABPI anyway? Well, think of it as a really simple checkup for the leg arteries. All it does is compare the blood pressure in the arm with the blood pressure in the ankle. And why do we do this? It's a critical safety check to make sure there's no serious issue with the arteries, which would make compression dangerous. Now, this patient's result is sitting pretty right in that normal range of 0.9 to 1.3. Think about that for a second. That one number is a huge piece of the puzzle. It's basically giving you a big green light. It tells us that the blood supply to his leg is good, and it pretty much rules out a significant arterial problem. Now, how you tell the patient this is absolutely crucial. You can't just throw numbers at them. You frame it as really good news. And then, and this is the most important part, you connect the dots for them. You say, because this result is normal, it tells us that compression therapy is the right and safe treatment for you. You're building a logical argument for the plan that's coming next. So with all that information, it's time to build our management plan. The best way to do this in the exam is to lay it out as a clear 4-point strategy. It makes you look organized and confident, and it helps the patient follow along and feel like they're part of the decision. So what are these 4 pillars? First, and this is the big one, we have to tackle that compression issue. We'll reintroduce it, but this time with a focus on getting a much better fit. Second, let's run some baseline bloods, things like a full blood count and inflammatory markers, just to make sure we're not missing anything else. Third, simple pain relief like paracetamol. And finally, number 4, some practical lifestyle advice, leg elevation, gentle exercise, that sort of thing. You can practice this exact case right now. Get objective feedback on mymediate.com. Okay, now we're getting to the really tricky part, the heart of this whole consultation. The patient has told you exactly what he's concerned about and what he expects. Your job is to negotiate, not just to give a flat no. This is where you really get to show off those advanced communication skills. So let's break down his first request. I want to see the doctor, not the nurse. This is a common one. How do you even begin to answer that without undermining your nursing colleagues or the way the practice works? While the absolute worst thing you can do is just dismiss him, the ideal response starts with validation. You say something like, "I can completely understand why you feel that way." Then you gently explain the nurse's specialist role in wound care. But here are the magic words. "And I will personally be keeping an eye on everything and reviewing your progress." That little promise builds so much trust.
All right, on to his next challenge for you. He's worried, and in his mind, the answer is a specialist referral. Again, just saying no is going to end the conversation and destroy your rapport.
And here is a brilliant technique you can use. I call it the conditional yes. You don't say no, you say, "Yes, we can absolutely look at a referral, but let's first try this improved compression plan for 2 to 4 weeks and see how we get on." See what that does? It makes him feel heard, it gives him a sense of control, and it gets him to agree to your immediate plan. It's a win-win.
And we're almost at the end, but you can't finish any consultation without two absolutely crucial things: robust safety netting and a crystal clear follow-up plan. This is what shows the examiner that you are a safe, organized doctor. And when I say safety netting, I don't mean a vague "come back if it gets worse." No way. You have to be super specific. You tell him exactly what to watch for. Signs of infection like more pain, redness, any discharge, or feeling feverish. And also any signs things are getting worse, like a new ulcer.
And the follow-up has to be just as concrete and specific. Booking him in with a nurse in just a couple of days to check that new stocking, that shows you're taking his comfort seriously. And that 2-week appointment with you, that proves you're sticking to your side of the bargain about reassessing for that specialist referral. It closes the loop perfectly.
So what's the big takeaway from all this? In a case like this, the medicine is only half the battle. Effective management is really about having the right conversation. You're turning a frustrated, non-compliant patient into a partner in their own care. So I'll leave you with this question. When you walk into that room, what's your strategy to build that trust? You can practice this exact case now on mymediate.com.